What makes public health personal to me is watching so many individuals suffer unnecessarily. From my days as a student in New York City with the AIDS crisis upon us and seeing that the authorities were not taking the action that was needed to be taken, to watching really all of these conditions affecting the poorest, the marginalized populations worse. I can't live comfortably and happily knowing that there's so much preventable suffering. So for me, public health puts equity at the center. It addresses and helps everyone in need of help at the level that they need, and working through HIV, viral hepatitis, COVID-19, and now liver diseases like steatotic liver disease, and specifically MASLD and MASH. I see the same story repeating over and over, and I see it getting better addressed each time, but still far too slowly. And the world felt that acutely during COVID-19, but we're seeing it again in steatotic liver disease.
That was today's guest, Jeffrey Lazarus. Hello and welcome everyone to Making Public Health Personal. This podcast is brought to you by the CUNY Graduate School of Public Health and Health Policy in New York City. I'm your host, Laura Meoli-Ferrigon. Thanks for listening. Today's guest is Jeffrey Lazarus, Professor of Global Health in the Health Policy and Management Department at CUNY SPH. He's also a research professor at the Barcelona Institute for Global Health in Spain. His decade-long career as a health systems, HIV, and viral hepatitis expert at the World Health Organization's Regional Office for Europe was followed by 3 years at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. He currently serves as co-chair of the HIV Outcomes Beyond Viral Suppression Coalition, a member of the board of directors of the Share Global Health Foundation, and as a member of the Global NASH Council and the EASL Public Health and Policy Committee, where he leads the Global Healthy Livers, Healthy Lives Coalition. He is author of more than 400 publications centered around liver health, viral hepatitis, HIV, and COVID-19. In today's episode, we'll discuss the most prevalent liver disease in human history and why it is largely unknown to the general population. Formerly referred to as non-alcoholic fatty liver disease, metabolic dysfunction-associated steatotic liver disease affects an estimated 38% of the global adult population and around 13% of children and adolescents. Jeff will tell us about the importance of assigning a new name and diagnostic criteria to the disease. We'll learn how to prevent it, reverse it, and the types of integrative services that are needed to change liver health globally for the better and end this silent epidemic. Jeff, thanks for joining me.
Thanks for having me, Laura.
So I want to start out by saying congratulations to you because you've recently been awarded the Distinguished Scientific Achievement Award by the American Liver Foundation. That's a huge deal.
Thanks. I'm incredibly honored, and it's a real recognition of what the field's been doing the last years in pushing the public health and policy agenda and moving beyond a focus on clinical research.
Has this award ever been given to someone like you who's not a clinician?
Not that I'm aware of. So I trained as what we call a doctor of medicine in the Nordic countries, but I'm not a medical doctor. So it's the equivalent of a PhD. So I'm really excited that it's not the basic scientist or clinical researcher who is given the award, but I see this really as an award to the field and to all of those clinical researchers who have been collaborating around the world on these large studies we've been conducting on public health and policy, on setting a research and action agenda, and ultimately on changing the name of NAFLD to MASLD, as you mentioned.
Great. So let's jump into what that is. Left unmanaged, MASLD can lead to cirrhosis and associated complications, including hepatocellular carcinoma, or HCC, which is the second leading cause of years of life lost amongst all cancers. An estimated 1 in 3 adults and 1 in 8 children worldwide have this form of chronic liver disease, and it's estimated to affect almost 2 billion people globally. How would someone know that they have this disease? What are the conditions for someone to be diagnosed with MASLD?
Firstly, you can get diagnosed now through non-invasive tests, whereas the gold standard is still considered a liver biopsy. There's a strong push in the field to have non-invasive tests, which means imaging or a blood test. So with a small blood sample, simple tests can be done to tell you if you have fibrosis, and then you can start to rule out why you have fibrosis. Is it because of hepatitis B? Is it because of hepatitis C, et cetera? And ultimately find out that you have MASLD. So the new criteria is related to having at least 1 out of 5 of these conditions. So having a high BMI, having a higher fasting serum glucose, having a high blood pressure, plasma triglycerides, or high level of cholesterol, of plasma HDL. So I don't want to get too much into those details. The point is that it's metabolic dysfunction associated. And although you may be drinking a little, you're not drinking a lot. If you're drinking a lot, you have alcohol-related liver disease. And if you have one of those conditions and you're drinking at certain levels, you'll have a combined condition, which is called MASLD. And that's one of the new contributions, because earlier it was like you have non-alcoholic fatty liver disease or you have alcohol-related liver disease. And the reality is there were people who had diabetes or obese or both and were drinking. So now we've really made a definition, a nomenclature that's fit for purpose and is transformative for the field. Because as you said, more than 1 in 3 adults have this condition. And most of the world does not know anything about this condition. And if we're going to address it, it's got to be addressed beyond the liver space, beyond hepatologists and gastroenterologists. We need it diagnosed by endocrinologists, because more than 2 in 3 people with type 2 diabetes have this condition, and we need it diagnosed in primary care. And there's a lot of simple things primary care doctors can do, including a simple test called FIB4, which is just really a simple online calculator that can be used that would start to give you an indication that you should have a follow-up confirmatory test.
And so you mentioned that this used to be called fatty liver disease. Why was it important to create this new disease category and change the name?
It was felt by some, including some patient advocates, that having the name fatty in the disease name would create stigma, or stigmatizing, could lead to discrimination. So there was a move to try and get the word fatty out. As we know in English, that's negative. Now, having excess fat in your liver is a health issue, and it will still be excess fat in the liver, steatosis. But by getting it out of the name, it means you can go see your doctor, they can explain the condition to you, and you can come home and say, I have this liver condition, it's called MASLD. You don't even need to spell it all out. And when they say, what do you need to do about it? There's a series of treatment and care options you have, but you don't need to come home and say, and mention the word alcoholic or fatty in the disease name, because it turned out, and I didn't think this would be the case, but just mentioning alcoholic made people think, oh, you've been drinking, or, oh, it's related to alcohol. And you say, no, it's non-alcoholic fatty liver disease. Oh, it's because you're overweight. And it just led to a conversation that was not working for some patients. And that's what really prompted the name change. Also, it's now a positive diagnosis, and it's more clearly linked to the metabolic dysfunction criteria that I outlined.
So why is MASLD a problem?
So having excess fat in your liver may not ultimately be a problem. The problem right now is that we don't know who it will be a problem in. So like many conditions, they don't all advance, but there's a certain likelihood that you can advance to advanced fibrosis, ultimately cirrhosis. You might need a liver transplant. It could lead you to die. It impacts on cardiovascular disease. It can accelerate diabetes, or moving from pre-diabetes to diabetes. There's a bi-directional relationship with diabetes. So having excess fat in the liver is just not healthy in and of itself. The moment you're diagnosed, we need to find out if you have other problems. We just don't know yet enough who it will advance in. And therefore, the idea is to diagnose people early, inform them what they need to do, because the liver is a very resilient and versatile organ, and you can reverse fibrosis when you catch it in the early stages. So we want to diagnose people early. If they have fibrosis, you can work to reverse it rather quickly. And if they have advanced fibrosis or cirrhosis, then there are other treatment options, and then it's a very serious issue.
So what causes MASLD, and how can someone who hasn't been diagnosed yet prevent it?
So what causes it is that excess fat in the liver, and that has a relationship to poor diet, to not enough physical activity. There can be genetic reasons, but it's also linked to those diagnostic criteria. If you have diabetes, if you're overweight, excess triglycerides, that's contributing to the excess fat in the liver. What can be done to prevent it? A healthy diet and exercise. And by healthy diet, it doesn't mean just reducing your caloric intake. It also means, what are you eating? And right now, there's a big focus on the big culprit, which is ultra-processed foods. So just, processed foods and those that are ultra-processed, poor quality, that's leading, to this excess fat in the liver, more challenging for the liver to process that fat through the system. So we want to be thinking about what we're eating, how much we're eating, and are we exercising? And that doesn't mean going to the gym every day. It means looking at your phone and saying, am I doing 8, 9, or even 10,000 steps a day? That's helpful. How can you do that? If you're in New York City like I am right now, you can get off the subway a few stops earlier. You can take the stairs instead of the elevator. Just you start to add on 1,000, 2,000, 3,000, 4,000 steps. You should also do some intensive exercise every week. But it's not as complicated as people think. On the other hand, there are social and commercial determinants of health. Where can we exercise? Do we live in a safe environment? Are there urban green spaces or is it too hot outside to exercise? And in terms of diet, are we being bombarded by advertisements for cheap, ultra-processed foods? Do we only have access to that kind of food? So while some people have called this a lifestyle disease, I think we shouldn't be putting the blame just on individuals. It's society that's created an environment that makes it very hard to exercise and very hard to eat well.
Yeah, and you mentioned New York City as an example. The city of New York just launched a Healthy NYC campaign. Can you tell us more about it and how liver health is central to this campaign's success?
This is a fantastic campaign, which I do truly applaud, launched by the mayors and the health commissioner's office about Healthy NYC. It has time-bound targets aligned with the sustainable development goals we want to reach by 2030, and it has very specific targets like increase life expectancy to 83 for New Yorkers by 2030. And life expectancy has gone down during COVID-19, so we need to get it back up again and increasing. Reducing cardiovascular disease and diabetes by 5%. And there's reducing overdose deaths. But important for us are going to be the other non-communicable diseases. So this is incredibly important because MASLD is intricately linked with cardiovascular disease, with diabetes. It's the hepatic manifestation of metabolic syndrome. So by thinking about your liver, you're helping your whole system. At the same time, by addressing your diabetes or your cardiovascular disease, you're helping out your liver. So I think, the mayor's program is quite ambitious, but is quite on target. So now we can all align to do this by 2030. So here at the City University of New York, at the School of Public Health, we can align. How are we contributing to that as a public school for New Yorkers, but also thinking globally? How can individuals in hospitals throughout the healthcare system think, how are we contributing to this? Where do we fit in? And so I look forward to the full program being sort of unveiled so that we can all be aligned, because it's a very ambitious and exciting program. And I think everyone can see themselves in it. But I think for most New Yorkers, this is a program that will really speak to them. And certainly from us in the liver field, it puts the liver front and center in achieving those goals.
Absolutely. And how long would you say this has been a global health threat? Historically, what led to the prevalence of fatty liver disease, which is what it was formerly known as?
Unfortunately, fatty liver disease or steatotic liver disease has not been recognized as a public health threat or even as a part of the public health agenda. It's not being addressed at all by the World Health Organization, at least directly, and we're trying to fix that. We held a World Health Assembly side event in May. That's the overarching or the highest governing body of WHO, and so we were able to engage with people there and have ministers of health putting this on their agenda. But we know from pretty good data from already 10 years ago that prevalence was over 1 in 4 adults. Now it's over 1 in 3 adults. That's a massive increase. You don't see many diseases increasing like that in such a short amount of time. So this needs to be addressed as a public health threat. We need strategies, action plans. And although I said it's front and center on the mayor's agenda, we need the mayor's agenda to specifically mention this. Because when I look and I do these policy reviews with groups around the world, and we look at diabetes action plans, cardiovascular action plans, the only time we ever see the liver mentioned is as a part of delivering on diabetes care and cardiovascular care. We need it mentioned by name so that we can raise awareness outside of the liver field among diabetes specialists, among primary care specialists, among cardiologists, but certainly among decision makers and policymakers.
If you dream of making a difference in the world, A public health degree or certificate can give you the tools to do just that. The City University of New York's Graduate School of Public Health and Health Policy equips public health professionals to advance not only a healthier New York City, but a healthier world for us all. We want you to join us in our mission. Visit sph.cuny.edu to learn more about our programs. No matter where you are in your career, CUNY SPH offers a broad range of degree and certificate programs to not only help you advance in your career, but to have a real impact on the world. Public health professionals are needed now more than ever. Join us. Visit sph.cuny.edu to learn more.
So why is this disease so poorly known?
One of the reasons is that we don't have a drug specifically targeting MASH, which is the more aggressive form of MASLD. That's what we really want to avoid. And so there's this sense of like, there's nothing we can do. But in fact, there's a lot we can do. As mentioned, treatment and care is about physical activity, improving your diet, but also addressing these other metabolic dysfunctions contributes to improving MASLD. I also think, and there's now studies supporting this, that when patients know that they have this condition along with other conditions, it can be a greater motivator to improve their health. And one thing I didn't mention, which is important, is that if you've been diagnosed with MASLD or MASH, you should avoid all alcohol. Alcohol is a major contributor to liver disease, but it's not the only contributor. And that's how non-alcoholic fatty liver disease was coined back by Ludwig and colleagues at the Mayo Clinic in 1980, because there were case reports of individuals who had all the characteristics of someone who had been drinking excess alcohol, but hadn't been. And then they realized something else was going on. And that's the name we ultimately changed. But back then, it just made really good sense to say this is non-alcoholic. So, it's about reducing the alcohol intake in general, but bringing it down to zero when you've been diagnosed.
So aside from reducing or eliminating alcohol, if you've already been diagnosed with MASLD, what can be done? A lot of us have grown up with this type of processed food. Is it too late, or how can we reverse MASLD?
It's absolutely not too late. So when you have a fibrosis stage 1 or 2, for example, it's entirely reversible. So it's about thinking about what you're eating. There's a lot of resistance from food producers to putting the ingredients and information and warning labels. And that's something we need to change. People need to realize, what they're eating. We certainly see when we buy medications, a packet with a lot of information. Yet when you buy processed food, there'll be no real information about, there'll be a list of ingredients, but it's not really unpacked. There's no potential harms explained. So in the absence of that, primary care doctors, other clinicians need to explain to their population, to their patients, that there are some foods that are healthier than other foods. So we want to be eating more fresh fruit, more greens and salad ingredients. That doesn't mean you can't eat any processed food. It doesn't mean you can't go out and have a burger or a piece of meat, but we have to do this in moderation. And we need to, walking around your house and walking to your car is not enough exercise. And that's really easy to monitor, because who doesn't have a smartphone that's not tracking your steps? I mean, now that's just a part of the packet we all have. So we should be looking at that and thinking about it. And doctors should be looking at it and saying, why are you averaging 1,500 steps over the last 2 months? That's a signal that something's going on. It could also be social isolation. It could be the weather. But there's something going on with that individual. And for sure, they're not getting enough exercise. And I keep going back to the step count. Obviously, there's apps, there's more advanced digital health tools and therapeutics. I'd encourage people to look at those. Some are approved by associations. But at a minimum, we can be looking at our step count and be thinking about the processed food we eat. Sometimes it helps just to write down for a week what we've been eating without even changing what we eat. Just write down what you eat and think, how many times did I have a hot dog, ice cream, white bread, and then start to think how, I can reduce this. You can substitute rice. Basmati rice is healthier than white rice. Right now, I'm in Spanish Harlem, and we've been talking with people about how do we keep allowing people keep eating what they want to eat, but we start to substitute some ingredients that are slightly healthier and not very much more expensive.
That's great. And you recently wrote a paper about social nutrition and social prescribing as being essential to MASLD treatment and care components. Can you explain what that means?
This is about not just telling people to go out and lose weight or go home and exercise. it's recognizing the challenges in weight loss and improving the diet, the quality of the food, and the challenges in exercising. So it's considering people's social setting, their context. Like I said earlier, is there a safe park? Are the streets safe to exercise in? Are the streets safe to walk in? Social prescribing has, as a part of one of its components, is to link people to community-based organizations. And certainly throughout New York and many cities around the world, there are community-based organizations that address food, health, food security. I mean, if you're on the edge and you don't have enough food, you're eating anything you can get. And so, talking to these organizations and linking care to that. And this was something similar to what we did in HIV many years ago. I mean, the role of community-based organizations, peers, in helping people get diagnosed, understand their diagnosis, adhere to their treatment. That's what we need in MASLD. We see it already now a little bit more in diabetes, where there's all kinds of online support groups and tools, but we don't have this in steatotic liver disease. We do for people who are drinking too much alcohol. We have Alcoholics Anonymous and other support groups, but we don't have it, what I call sort of the left side of the spectrum, for those who have diabetes or are overweight and then get diagnosed with MASLD. So social prescribing links people to support in their community. Social nutrition recognizes what the nutritious options are in their area and can provide information about it. And when we talk to clinicians, they say, this does get challenging for us in the short amount of time we have. But that's why we need models of care that are more multidisciplinary, that include nutritionists and dietitians. We need primary care physicians that can at least have a pamphlet or offer a website where people can get more information if they want to.
That's great. So when we speak about healthcare professionals, why is it important to integrate services in our community?
We're never going to get anywhere with just a narrow, siloed focus on MASLD. MASLD is really a window to what's wrong in society. We're not exercising. We're not eating well. And that's what I like about the Sustainable Development Goals. So when we did this index looking at where MASLD fit in development and health, we realized urban green spaces, education, gender issues, socioeconomic issues all needed to be addressed. When I talk to clinicians, they say, that's a tall order in the short amount of time I have with my patient. But that's where the city plays a role. And that's going back to, the mayor's initiative. That's where they need to say, we're not going to reduce cardiovascular disease, diabetes, and MASLD if we don't have, safe parks, if we're allowing McDonald's to be built across from the high school, if we don't have healthy options in schools and near schools. And some initiatives have said we won't close existing, shops and fast food stores, but we will make sure zoning doesn't allow new ones that are very close to the schools, because I do believe it comes back to educating this generation. And this generation is growing up on a lot more fast food than people were growing up on in my generation or 2 or 3 generations ago. So we have a long way to go, and we are going to need structural changes. We can't just rely on the individual. And social nutrition and social prescribing is saying it's not just on you, it's on the context where you live, and there are support groups that you can be connected to.
So that sounds like public health as opposed to personal health.
Yeah, this is the public health approach to liver care. And that's why I'm so excited about this award. I'm very honored to win it. But for me, it marks a recognition in the field that this is now a public health issue, will require a public health response. Liver specialists will be central to that response, but they clearly need nutritionists, diabetes experts, primary care, peers, community-based organizations, and others. Otherwise, we will not get out of this situation where more than 1 in 3 adults are estimated to have MASLD. And when MASH-specific drugs do become available, I very much hope, and we're working on trying to contribute to this, that we'll have nutrition-aligned drug rollout. So we'll actually be able to help people eat better, exercise more, and get the medications. And I think we'll see much better outcomes than some of the trial results when we add those components as a part of the treatment and care package. It's just been exciting to start to pivot full-time to addressing liver health and helping liver health become an integral part of public and global public health.
So how do you feel to be making such a difference in public health globally?
It's an incredible opportunity that I seize, and I've been leading with colleagues large collaborations. So on COVID-19, 386 people from 112 countries and territories. We've had more than 450 people involved in the MASLD process, a smaller group working on the name change, but the large group working on different aspects of setting the first priority and action agenda for the field. It's an incredible honor to be able to work with so many people and see a large consensus for the first time in addressing this and setting an agenda to address this. Now, I hope that the mayor's office in New York, the health ministers around the world, and ultimately, and hopefully very soon, the World Health Organization will really take up this issue because it will make it a lot easier. Right now, it's a bottom-up approach. We need a top-down approach as well.
Thanks again, Jeff, for being a guest, and thanks for listening to Making Public Health Personal, presented by the CUNY Graduate School of Public Health and Health Policy in New York City. You can now share, like, and subscribe to our show anywhere podcasts are heard. To find out more about our school, you can visit sph.cuny.edu or connect with us on social media. We're on LinkedIn, Twitter, Facebook, and YouTube. Just search CUNY SPH. This is your host, Laura Meoli-Ferrigon, signing off. And while public health has a global impact, that doesn't mean we can't make it personal.